certain ground rules that we have to follow. Duration of each paper is going to be 5 minutes. You can't change the name of the presenting author. Membership number up to 28934 are ratified. Anything beyond that is not ratified and not eligible for an award. बाकी तो मेरे लिए ही है. All right. Let's go ahead with the first author, Dr. Srividya. Is she here? Come. Yes, sir.
Good evening. So my topic is MGD in India, what to do. Our international workshop on MGD has described MGD as chronic diffuse abnormality of the meibomian glands characterized by terminal duct obstruction along with qualitative or quantitative changes in the glandular secretion. Dysfunction in meibomian gland secretion can adversely influence the amount and also the quality of secreted meibum, leading to alterations in tear film compositions and compromising ocular surface health. This will result in tear film abnormalities, ocular surface inflammation or irritation, or ocular surface diseases. The aim of our study is to compare the efficacy of basic treatment modalities of meibomian gland dysfunction. All the patients in our study, they belong to lower socioeconomic group and cannot afford expensive treatments. Our objective is to give better treatment at reasonable price. So it's a prospective cohort study with 120 patients, 2 groups of 60 each. In the first group, we have given only warm compressions and lid hygiene along with supplementation of lubricants for 1 month. Whereas in the group B, along with these, topical antibiotics were also included. These are the parameters under study: symptoms by OSDI questionnaire, tear film assessment, ocular surface staining, and eyelid morphology. We have excluded patients with seborrheic dermatitis and acne vulgaris. Coming to our results, while we see improvement in symptoms in group A, there is 40%, and in group B it is 90%. Improvement in eyelid morphology is seen in 32% in group A and 82% in group B. Ocular surface staining, betterment is seen in 28% in group A, and group B it is 76%, whereas tear film assessment is almost same in both the groups, that is 68 and 76% respectively. In general, when we come to the different treatment modalities of MGD, regular eyelid compresses with warm water once or twice daily, followed by a firm massage to express insufficiented secretions, is a beneficial treatment. Artificial lubricants, topical antibiotics like azithromycin and emollient or liposomal spray may be considered case to case. Topical 1% ophthalmic solution of azithromycin is a broad spectrum macrolide antibiotic with anti-inflammatory properties. The most important thing in MGD is its daily eye care regimen. That is warm compresses for 10 minutes, cleansing the eyes with baby shampoo or lid scrubs, and using preservative-free eye lubricants. Without proper maintenance, MGD will worsen and the number of meibomian glands will eventually decrease. As the disease progresses, symptoms worsen and prescription medication or surgical intervention may be necessary. There can be permanent damage to the eye and vision loss also in some cases if left untreated. It's a chronically recurring disease. Patients will tend to have temporary relief. Symptoms usually reappear after some time without ongoing treatment. Hence, patient education is essential to ensure maintenance and regular follow-up. The limitations of our study are we haven't separated the MGD into, like we didn't classify it basing on its severity, and acute and chronic differentiation was also not done. Coming to conclusion, MGD is a very prevalent yet often overlooked disease leading to underdiagnosis and undertreatment. Many patients are asymptomatic in the early stages, complicating its prompt diagnosis and intervention, and it's mostly an incidental findings on slit lamp examinations. Better improvement was observed in patients with topical antibiotic usage along with lid hygiene and also lubricants. Thank you.
Thank you so much. What was the general age group in which you have picked up the patients?
Sir, it is from 20 years to 60 years.
And what was the predominant age group which was
It's generally 45 to 60 was predominant, sir.
And what is the rationale behind putting eye drop instead of applying it on the lashes or
Sorry,
the lid
sir?
margin?
I didn't get it.
You said that the azithromycin eye drops were used.
No, sir, eye ointments.
Eye ointment. Okay. Fine, thank you.
Thank you, sir.
Uh, is Brinda present? Okay. You'll need to sign here, Brinda, first.
Good afternoon, I am Dr. Brinda. I will be presenting my paper on evaluation of dry eye in rheumatoid arthritis and systemic lupus erythematosus and its association with anti-SSA and SSB autoantibodies. As we all know, dry eye is a multifactorial disease and the ocular surface is maintained by a tight immune regulation. In autoimmune diseases, this immune regulation is breached, and autoimmune disease has two types of dry eye, which could be primary Sjogren or secondary Sjogren. In primary Sjogren, it's associated with anti-SSA and SSB autoantibodies. In secondary Sjogrens, we suspect self-reactive immune T cells, which causes lymphocytic infiltration in the lacrimal glands, which impairs the tear production and results in dry eye. The aim of our study was to estimate the prevalence of dry eye disease in rheumatoid arthritis and SLE patients and to identify the association of dry eye disease with anti-SSA SSB autoantibodies. The study group included patients above 18 years of age with rheumatoid arthritis according to ACR-Euler 2010 criteria or SLE according to ACR-SLIC 2012 criteria, and we recruited 90 RA patients and 55 SLE patients. The exclusion criteria were active keratitis and conjunctivitis, cicatrizing ocular surface conditions, and lacrimal gland malignancies and sarcoidosis. Methodology was, we noted the duration of the disease, and disease activity was calculated based on the DAS28 or SLEDA index. Dry eye symptoms were noted, and the patients were subjected to two structured questionnaire, OSDI questionnaire and speed questionnaire. Topical and systemic medications were noted, anterior and posterior segment examination was done, and the patient was subjected to Schimmer's test, ocular surface staining, done with two scoring systems, SICA OSS scoring and National Eye Institute scoring, and tear film breakup time was noted. Serology was done to look for anti-SSA SSB autoantibodies. Coming to the results, in RA group, the mean age of the population was 44 years, and in the SLE group, it was 32 years. And in both the groups, majority of the population were females, and the median duration of the disease was 6 years in rheumatoid arthritis and 7 years in SLE. The disease activity in both groups, the majority of the population were in remission or low disease activity in RA and no flare with SLE. Symptomatic dry eye disease in rheumatoid arthritis was 32 patients had self-reported dry eye symptoms, and on structured questionnaire, speed questionnaire was able to assess more dry eye patients when compared to OSDI. This discrepancy was because some questions in the OSDI were not applicable to the Indian setting. The similar pattern was noted in the SLE group also. 14 patients had self-reported symptoms and 29% of patients had dry eye based on speed questionnaire. Dry eye disease prevalence in RA and SLE group, the majority of the population in both groups had abnormal tear film breakup time and ocular surface staining when compared to OSDI or speed scores and Schimmer's test. Tear film quality was affected more than the quantity, and this suggests the subclinical dry eye disease was more prevalent than the symptomatic dry eye disease. Despite the symptoms in both groups, which was 35% in RA and 25% in SLE, less than 5% were diagnosed with dry eye and were on treatment. This highlights the need for vigilant screening for dry eye, irrespective of symptoms, disease duration, and disease activity. Relating to dry eye disease to the disease duration and activity, in both RA and SLE group, there were no significant association. Still, the patient had abnormal TBUT and ocular surface staining scores. This suggests a subclinical dry eye disease with minimal disease activity. Majority of the patients had meibomian gland dysfunction. This was explained because of immune complex deposition in the meibomian gland and like methotrexate usage in rheumatoid arthritis patients, which aggravated the blepharitis. So lid examination is as important as the tear film assessment in case of dry eye disease. Anti-SSA SSB autoantibodies were detected low in rheumatoid arthritis patients, and anti-SSA was 31% positive in SLE group. Still, the dual antibody negative patients had abnormal TBUT and ocular surface staining scores. Coming to the discussion, in our study we have found abnormal ocular surface staining and TBUT scores were more than the abnormal Schimmer scores. Ocular surface inflammation was more than decreased tear production, no significant association with SSA SSB autoantibodies. Anatomical target was ocular surface epithelium than the lacrimal gland, which is because of increased pro-inflammatory cytokines on the ocular surface. Secondary Sjogren syndrome pathway could be a minor mechanism causing dry eye. Postulated dry eye pathway, it's because of multiple risk factors causing autoreactive T cells, abnormal neutrophils, or activated corneal Langerhans cells resulting in the ocular surface inflammation. And the strengths of a study was, it is the first study to report dry eye disease in both the SLE and RA groups, and the first study to utilize two subjective dry eye questionnaires, OSDA and SPEED, demonstrating a SPEED has greater applicability in our setting. Limitation was, we did not assess for the tear film hyperosmolarity, and majority of the patients were in like remission or low disease activity. We did not, severe disease activity was not noted, so the correlation with the dry eye disease cannot be commented. Conclusion was, dry eye disease is not associated with SSA-SSB autoantibodies, disease duration and disease activity. Subclinical dry eye is more prevalent in SLE and RA groups. Vigilant screening is advised, and dry eye symptom assessment should be done, followed by tear film quality, quantity, and lid examination is very important in dry eye disease patients. These are my references. Thank you. Thank you, sir.
Have you done any inflammatory markers for any of these in the tear film?
No, sir. Not
So your study is only based on the antibodies and their correlation to the disease.
disease. Yes,
And
sir.
you were saying that
It's
they have
not,
no
association.
correlation, it can always be there in
Yeah.
spite of the antibodies being present.
Negativity.
Okay, thank
Thank you.
you. We missed out on Dr. Vishal Nandeshwar.
Good evening everyone, myself Dr. Vishal Prakash Nandeshwar, presenting on the topic an observational study of prevalence of dry eye in newly diagnosed untreated depression patients. Introduction: dry eye disease is a common multifactorial problem with a varying prevalence rate of 5 to 34%. Numerous exposures including medication use, hormonal changes, environmental exposures and neural alterations are involved in the pathogenesis of dry eye. Common symptoms of dry eye patients include pain, irritation, itching, burning and grittiness. Dry eye syndrome involves multiple risk factors that, when disregarded, can result in a treatment failure and frustration both for the patients and the physician. It poses a huge economic burden to patients if not evaluated for risk factors that may result in delay in treatment. It affects the quality of life of patients with regard to daily visual acuity. It results in a social stigma as a patient may have chronic red eye. Patient may go in for depression. Like dry eye, depression is also chronic disorder nowadays. Both affects the quality of life. Many studies have been reported that an association between the dry eye and depression, both post-traumatic stress disorder and anxiety and dry eye. Previous studies report the prevalence of dry eye disease in depression is 29%. Aim and objectives of my study was, has been undertaken to determine the prevalence of dry eye disease in newly diagnosed depression patients without any previous medications. Material and method: study design. It was cross-sectional observational study on the sample size of 100 patients who were newly diagnosed depressive disorder patients from Psychiatry Department of Ispat General Hospital, Rourkela, Odisha. Study center was Department of Ophthalmology and Department of Psychiatry, Ispat General Hospital, Rourkela, and study period was 6 months. I have included the patients of age more than 18 and less than 17 years old and newly diagnosed depressive disorder patients without any previous medications. And age less than 18 years and more than 70 years, in depressive disorder patients on drugs, ocular infection, inflammation patients, taking antihypertensive, antihistaminic, anti-tussives, anti-androgens, topical eye drops, contact lens wearers, previous history of ocular surgeries, history of autoimmune disorders and pregnancy, thyroid disorders and lead anomalies were excluded from the study. Methodology: newly diagnosed depression disorder patient with no history of medication got selected with proper written informed consent from Psychiatry Department. All patients were diagnosed and classified as a mild, moderate, severe depressive disorder on the basis of ICD-10 classification for depressive disorder by the psychiatrist. On the same day, all patients undergoes a complete ocular examination and dry eye tests. Dry eye is said to be present if minimum 2 tests were positive. Since there was no significant difference between the right and left side tests, I took right eye as values for statistical purposes. The information collected regarding all the selected cases were recorded in a master chart. Data analysis was done with the help of the Spaces software, and the p-value was calculated. The p-value less than 0.05 is taken to denote the significant relationship. My results: age distribution of the studied 100 population, 20% were less than the 30 years of age, 27% patient between the 31 to 40 years, 31% between the 41 to 50 years, 22% persons at more than 15 years of age. This is the graphical representation of the age distribution. Age versus dry eye. Of the 100 studied population, only 4 patients had dry eye in less than 30 years of age group. 10 had dry eye in 31 to 40 years of age group, 14 developed dry eye in 41 to 50 years of age group, 14 showed dry eye in more than 50 years of age group. This is the graphical presentation of dry eye versus age. Sex distribution among the 100 studied population, 45% were males and 55% were females. Blink rate distribution of the 100 studied population, 40% had normal blink rate, 30% had grade 2, that is 75% of normal blink rate, 22% had grade 3, 8% patients had grade 4, 25% of normal blink rate. Tear film breakup time distribution of the 100 population, 60% had normal TBUT, more than 10 seconds, 27 had 6 to 10 seconds, 12 had 2 to 5 seconds, and only 1% showed less than 2 seconds of tear breakup time. Shermer's score distribution of 100 studied population, 62 patients had normal Shermer's score, 30 had 6 to 10 mm, 7 patients had 2 to 5 mm, and 1 patient had less than 2 mm score. This is the tear film meniscus height, 63% less than 0.3 mm, and 37 patients shows less than 0.3 mm. Severity of depression versus dry eye. Of the 100 studied population, 38 patients belongs to mild depression group, 35 belongs to moderate depression, 27 had severe depression. In that 38 patients, 5 patients had dry eye. In 35 patients, 17 had dry eye, and in 27 patients, 20 had dry eye. This is the graphical representation of the severity of depression versus the dry eye. This is the prevalence of dry eye. Among 100 studied population, 42% had dry eye, 58% did not have dry eye. The prevalence of dry eye disease in by patients of depression is 42% in my study. Discussion: if dry is not evaluated for risk factors, it leads to an economic burden to the patients. Many studies have shown the relationship between the depression disorder without any medication, that is prevalence of dry eye in the depressive patients. In our study, the prevalence of dry eye disease is 42%, which correlates with the literature of Nandi et al. 1992. In our studied 42 patients among 100 studied population developed dry eye disease. It shows that dry eye disease will occur in even newly diagnosed depression patients also, and not the antidepressant alone can cause the dry eye. Conclusion: so from this study, it is clearly seen that depression itself causing dry eye disease, not only the antidepressant which are using for treating the depression. If we do not diagnose the dry eye early and not treat it properly, then may go for serious complications like corneal melting, perforation, and eventually vision loss. So it is very important that psychiatrists take this into account, especially while prescribing antidepressants, which also aggravates dry eye disease, and send the patient for ocular screening for dry eye disease once they diagnose the depression, to avoid such complication and to provide patients quality of life. These are my references. Thank you.
So all these patients, what did you treat them with?
Yes, sir.
Was there a difference in the treatment for the psychiatric treatment? Was the drug changed if they were diagnosed as a dry eye?
No, sir. If they are diagnosed with a dry eye, then we used to say to psychiatrists that they can go for a very mild treatment of depression, because already if they have...
There can't be a mild treatment or a moderate treatment. There are different drugs available. So were the drugs changed for the treatment of depression? Did you ask them? Did you find out what they did eventually if you have diagnosed the patient as a dry eye?
Yes.
Is their treatment going to change?
So I have not asked.
And after the treatment, did the dry eye improve?
Those patients who came to me, their symptomatic relief, sir. Symptomatic relief I have found.
You've not checked the other criteria that you were
Yes.
used for diagnosing. Were there different types of depression that you went into? You have taken a generalized depressive disorders.
Sir.
There are different types of depressions. So
Sir, I have
was it
taken,
different in
I have
different?
taken the depression for more than at least 2 weeks, the patient.
No. I'm talking of different thing. In depression, there are sub-diagnoses.
Yes, sir.
So did you check for those?
No, sir, not other.
Like bipolar disorders,
No, sir.
those kind of?
Only depression.
Okay, fine. Thank you.
Thank you, sir.
Yeah, sure. Yeah, sure. Why depression should cause dry eye? Because of that. It decreases the quality of your life.
Whose screen time is more, they come to me for complaint of dizziness in eye and all those problems related to dry eyes. So I tell them to reduce the screen time. That is the best treatment.
Yes.
And I prefer to give some lubricant in the form of ointments, like MCM ointment, which is carboxymethyl cellulose with glycerin. Ointment is more effective than liquids. So I have not seen any patient who has gone into depression. I am working there for last 17 years, and dry eye is a common symptom there. So no patient has gone into depression.
So he's talking of a different thing. He's talking about diagnosed depressed patients having dry eyes. That's his paper. It's not about dry eyes causing depression.
Yes.
Yes, depressive medicine can cause dryness.
No, without treatment. So his point of contention is, if there is a patient who has depression, he is postulating that because of the serotonin receptors on the ocular surface, the depression itself can cause changes on the ocular surface, which will cause some amount of dry eye. So it's a pathological dry eye. What you're describing with relation to the screen and the students is more of an evaporative dry eye because of less blinking. So it's a computer vision syndrome. So it's a reversible thing.
Yes.
Yeah. Thank you.
Thank you, sir.
Is Divya Srivastav here? Mr. Dr. Ankit Agarwal?
Very good afternoon, everyone. The topic is an innovative low-cost dry eye treatment. Now, dry eye is defined as a dysfunction of lacrimal functional unit, an integrated system comprising of lacrimal glands, ocular surface, lids, and sensory and motor nerves that connect them. So mostly the dry eye, the common type is, in India is MGD based, which is associated with diabetes and poor lid hygiene. Also, the weather here is more humid, therefore MGD is more common here. The treatment modalities for dry eye most commonly use lubricants like CMC or anti-inflammatory agents like cyclosporin and steroids. Now, various device-based therapies have come up in recent years, the example of LipiFlow or IPL. However, these devices are very costly and the patients can't really afford the therapy for long term, and the doctors also are not able to buy these machines to give the therapy to the patients. Keeping this in mind, we have designed an innovative approach to dry eye treatment where a low-cost device is used which is similar in effectivity to LipiFlow. The purpose of this study is to describe an innovative low-cost dry eye therapy system as compared to much costlier alternative available in the market. The study was performed at a eye hospital in North India. A therapy protocol was designed where low-cost heater cum massager, costing rupees about 10,000, was used to treat dry eye diseases caused due to meibomian gland dysfunction. A data of 39 patients aged between 43 to 59 years was collected. Of these, 27 patients went therapy using novel device, whereas 12 underwent therapy using traditional treatment of warm compressors, what we tell to the patients. Now, this is the massaging unit which I am going to demonstrate about. So, this is how the unit is placed on the patient's eye, and as per the protocol which I have designed, I will explain. Now, what it does is that at optimal temperature of 41 to 42 degrees Celsius, it keeps the warmth to the eye, area around the eye. And it has compression also, which gives compression at the interval of every 3 seconds. So, apart from heating, compression is also done in areas around the eye. This leads to loosening of the clogged meibomian orifices, thus resulting in resolution of MGD. The device is used for 15 minutes at a time, and once every 3 days for 15 days, that is total 6 sessions were done. Now, at the end of 1 month and 3 months, the following diagnostic tests was carried out, that is Shermer's test, TBUT, and OSGI questionnaire. All the patients were prescribed 1% CMC eye drops as a placebo effect. The results of these 3 tests were compared with those of traditional therapy group and with values from before treatment. Thus, what we see here that the mean values pre-treatment of Shermer's test was around 25 millimeters in both the groups, Now this Charmat is more than normal, we might say in the epi-4 range, because of the inflammation caused due to MGD. Now at the end of 1 month with novel device treatment, the Charmat value has decreased to 16.7 millimeters, whereas in the traditional therapy it has gone to 19 millimeters. While at the end of 3 months it has gone to fair of normal range, 14 mm, and at the end of 3 months for traditional therapy is also around 14.7 mm. So what we see here is that at the end of 1 month, the novel device therapy has a much better treatment result, but at the end of 3 months, both the devices have a similar efficacy. So the novel device gives a faster resolution. The patients in both were also symptomatically much better from before therapy. The conclusion is the innovative solution is a low-cost dry eye treatment alternative to devices which are available commercially and thus makes the therapy accessible to a majority of doctors and patients who otherwise would not be able to afford to buy them or pay for their therapy respectively due to financial constraints. Thank you.
Ankit, have you patented this device?
Sir, I have not invented this. This device is available commercially on Amazon. I have just changed the software a little bit and made it like I have checked the temperature that it should give a continuous 42 degrees Celsius and 15-minute cycles. That's what
So you have not given the credits for that particular thing, right?
No, but it's generically available in.
If it is available in the market, it's not your device. You're supposed to give a credit to the person who has given it to you. Okay. Second thing is, did you document the meibomian glands, pre and post?
Yeah, we don't have.
how?
We don't have a mammographer with us. So using an autoref, we try to take pictures of the meibomian gland. So that's all the documentation I have. So what I noticed was that there was some improvement in the meibomian gland, but the pictures were not very clear. I could not, demonstrate them using the slides.
Now, how did you measure the T-butt? Did you measure the T-butts with the lubricants on or without the lubricants?
No, the T-butts were measured without the lubricants 3 days back. 3 days of lubricant were stopped. Then T-butt were measured, and we used moxifloxacin eye drops to moisten the Shermer's, the fluorescent strips to do the T-butt.
You have a topographer?
I don't have.
Okay. Thank you.
Thank you, sir.
Is Divya here? Dr. Shubhi Sachan? Dr. Ujwal?
Good afternoon, everyone. My topic is correlation of vitamin D levels and severity of dry eye disease in Jharkhand. Dry eye is a multifactorial disease of the ocular surface characterized by a loss of homeostasis of the tear film accompanied by ocular symptoms. The prevalence of dry eye disease in India is higher than the global prevalence and ranges from 18 to 54%. The community-based Indian study reported vitamin D deficiency prevalence of 50 to 94%. Aim is to study the correlation of vitamin D levels and severity of dry eye disease. We have to assess the prevalence of vitamin D deficiency in dry eye disease patients. An observational cross-sectional study was done in 116 patients with dry eye who came to our OPD in the span of 12 months. All patients with dry eye disease in the age group of 20 to 50 were taken, excluding the patients having screen time more than 4 hours, thyroid disorders, meibomian gland dysfunction, contact lens user, or on anticholinergic and other drugs. We did best corrected visual acuity, slit lamp examination, tear film breakup time, Shermer's test, and calculated the OSDI score and did vitamin D investigation. The mean age of my sample size is 35.25. Females were more in my study. Moderate dry eye disease patients came out more in my study. Vitamin D deficiency in severe dry eye disease was maximum 60%. where the mean vitamin D values in severe dry eye disease patients were 16.2, minimum being 5.3 and maximum being 31.2. In 40 to 50 years age group, 53% of the patients had vitamin D deficiency, with mean vitamin D values 17.9. Females were more prone for vitamin D deficiency. The mean value of vitamin D came out to be 17.61 nanogram per ml, which was statistically significant among 48% of total dry eye disease patients. The OSDI score in vitamin D deficient patients was 28.6 and in adequate vitamin D patients was 19.4, which corresponded to the study done by Jing where vitamin D levels were lower than in healthy controls by 4 nanogram per ml and an OSDI score that was significantly higher by 10.70. Both dry eye disease and vitamin D deficiency are highly prevalent but very underdiagnosed and undertreated worldwide. Vitamin D acts as an immunomodulatory agent which makes the corneal epithelial cell barrier function better. It reduces inflammation and tear osmolarity and improves the stability of tear film. Vitamin D deficiency is mainly due to inadequate sunlight exposure and inadequate vitamin D in diet. The significant decrease in vitamin D levels suggests that low vitamin D levels is associated with dry eye disease. Vitamin D deficiency in my study was seen more in the severe dry eye patients in the age group of 40 to 50 years and more in females. So, diet rich in vitamin D should be encouraged. Adequate exposure to sunlight should be encouraged. Vitamin D supplements may be added if not responsive to conventional tear substitutes. Thank you.
Thank you, Ujjwal. Ujjwal, are you a vegetarian?
No, sir.
Have you done your D levels?
No, sir.
I am a non-vegetarian. My D levels are below normal. Why?
Vitamin B12 may be lesser.
So genetically brown skinned people, yellow skinned people are prone to have vitamin D deficiency because of their low ability of their melatonin not to convert the sunlight into vitamin D.
Yes, sir.
Okay.
Yes.
So apart from that, that is one of the main criteria. So what have you given new to us by doing this study?
In my study, all the patients of dry eye disease were taken. The vitamin D deficiency was seen more in the severe dry eye disease patients. So it will be much more beneficial in severe dry eye disease patients to give to check for vitamin D levels and if needed vitamin D supplementation can be given to them.
But even the mild dry eyes had a vitamin D deficiency, right?
They have, yes.
So why wouldn't you give them a vitamin D prophylaxis?
It is means first we need to check the vitamin D diet. In diet we should give
Okay. Why do you think females have more of a vitamin D deficiency in your study compared to the males?
Females means they do much more indoor activity and exposure to sunlight is a bit lesser.
So you're in Jharkhand, right?
Yes.
And what was the demographic thing about the population that you did?
Females were more in
No,
my
but
study.
what kind of people? What kind of population? Was it a middle class, working
yes,
class? Was it a poor class? What kind of patients are we looking at here?
Middle socio-economic class patients.
So,
Yes.
so all the females were housewives.
Not all of them. Means maximum of them were.
So you'll need to have more of these bifurcations for your study to have something more fruitful, which can actually get published then.
Yes, sir.
So Sagarika Lad, not there. Subhi Sanchan and Divya Kattiyar. So I think we'll call it a session now. Thank you. Thank you, everybody. You all want to have a discussion about anything else, you're always welcome. We still have time. So for them, so they need to take frequent breaks. They have to. I have always, how many of you have taken overnighters in your medical career? Overnight, malab, studied the whole night, studied the whole day. Why? Did it make a difference? Did it? Seriously, I'm asking you all. So did you think that all-nighter that you did made a difference of 5 marks or 10 marks or whatever in your grade? So if you would have put 3 hours a day for their whole year, wouldn't that have been better? That's the way to go about it, but none of the students understand that. I have never not slept for more than 10 hours every single day of my medical career, whether it's an exam or whether it's not. So if you are going to distribute your work intelligently, that's the way to do it. And everybody will have a way of working. You can always make a thing for it. That. So generally, none of your students are going to put the eye drops the frequency that you're going to tell them. That is one. Apart from that, they are into gaming. So it's not only those 8 hours of work that we are talking about, we are talking of extracurricular screen time as well. So I'm telling you from my son's experience.
They are not doing it. Their work is too hard. I have seen them in hostels. I do frequently visit the hostels. They have to work hard. They can't stop. So I tell them to take frequent rest, as you told, and take frequent heat to the eyes.
Too much of heat also is not a good thing, because the more you heat the surface, it causes more inflammation. In fact, in meibomian gland disease, if it's an inflammatory disease, we do not recommend warm compresses in the initial stages. We need to decrease the inflammation and then start the warm compresses. So in the initial stages, in fact, ice compresses would be a better option. Slowly, once the inflammation drops down with what they called about the azithromycin and other things, you use those supplementary treatment, maybe mild steroids or an immune modulators that you would use, and then start the treatment for the actual meibomian gland disease. So,
Ketorolac eye drops along with lubricant.
okay,
So that gives a better result.
fine, that's good. So you'll need to decide what kind of a dry eye it is. You are not going to get a pure evaporative dry eye. You're not going to get a pure Sjogren's or something of that sort. So Sjogren's is a different thing that we are treating. Steven Johnson's is a different thing that we are treating. But when you're talking of computer vision syndrome, it's the frequent breaks that work. You need to tell the patient that you need to decrease the AC temperature. You need to increase the humidity in the room. You need to have humidifiers if it's a dry state, like Jharkhand would probably be very hot. So these are the places where humidifiers work. Now, a simple way of having a humidifier is to have a matka with the water in the house. Even that works as a humidifier. So these kind of small innovative things for low socioeconomic conditions will work, will go way ahead. I always tell my patients that when you're in the car, don't have a blast on your eye or on your face. Your temperature should not be going that low. Even when you're sitting under the fan, see to it that you're sitting away from the draft of the wind. So these things you need to talk more in depth with the patient. Then the patient realizes that, okay, if I do this, I'm better off. If I'm not, then again there will be a seasonal variation. So it depends on each of them. So initially I always like to start using a carboxymethyl cellulose. Sodium hyaluronate is a bit overrated. is promoting epithelial healing and everything, but mainly you have to realize that the pharmacological companies are not promoting CMC because it's under price control. That doesn't mean that it's a bad drug. It's actually a good drug. There used to be a preservative-free Celluvisc which used to be available, which used to do wonders to severe dry eyes. So it used to be a 1% solution. So if a person has an access to abroad countries, they can always have it. It's very cheap in USA and in UK. So that drug really works well. Apart from that, all these new drugs, whatever said and done, SOC ho, whatever they call soft preservatives, they still are preservatives. So the best way is a preservative-free formulation. Very few companies are giving you preservative-free anything. Yes, yes, but people have stopped manufacturing it because of the price control. And the people who are manufacturing it don't give you in that quality. Yeah, yeah, it does. No, it works in mild to moderate cases. In computer vision syndrome, it works ointment. But apart from that, there are so many other factors to it that need to be seen into. Thank you so much.